Hello, my name is Dr. Andrew Way from the Peter MacCallum Cancer Centre and Royal Melbourne Hospital in Melbourne, Australia, and I'm going to give you an AML update as part of the Research to Practice Year in Review. So let me just start by showing you an overview of the current landscape for AML, which includes some drugs which are close to FDA approval, such as quizartinib, but not quite there yet. And I will go through various aspects of this landscape and what are the new pieces of information which are relevant for our clinical practice. So let me start with the FLT3 arena, where we currently have midostaurin as the main frontline therapy for patients with FLT3 mutant AML. We know that last year, Harry Erber presented the very important randomized study showing that quizartinib was superior to placebo as frontline therapy for patients with FLT3 mutant AML. So the question now becomes, which drug is now standard of care once both these drugs are available, midostaurin or quizartinib? Well, firstly, we can't compare these trials directly because they don't have completely overlapping populations. For patients with FLT3 TKD, the obvious choice is midostaurin because quizartinib is inactive against FLT3 TKD abnormalities. Second, midostaurin, the indication doesn't allow for maintenance therapy, particularly post-transplant, whereas quizartinib does offer 3 years of post-transplant maintenance. This becomes critical because we recently heard of the results of the Morpho study, which was gilteritinib versus placebo as maintenance therapy for patients after allograft for FLT3 mutant AML. And we all expected that to be positive. With that study not meeting its defined primary endpoint, we now would only be able to look to quizartinib as offering the potential for post-transplant maintenance therapy. The other key question is whether all patients should get post-transplant maintenance therapy in view of the Morpho study not meeting its primary endpoint. We do hope for more information about the Morpho study in the coming months, and I think the subgroup analyses will be very informative. However, there have been a number of clinical studies now published, which are really putting forth the notion that perhaps we should be using the FLT3 ITD MRD assay, which is performed by highly sensitive NGS techniques, as a way of trying to stratify risk in patients with FLT3 mutant AML. This is a test which is sensitive down to 10 to the minus 6, so very sensitive PCR NGS-based assay, which can pick up very low levels of FLT3 mutant disease. This is one of the papers published, which was from our group, which shows on the left about 100 patients with FLT3 mutant disease and MRD being done prior to transplant. On the top, you can see patients who are positive by the conventional method, which is capillary electrophoresis, which you can see only detects a small proportion of patients with positivity, whereas in the blue in the middle, you can see this new PCR NGS-based assay picking up a whole bunch of patients who are positive pre-transplant compared to those who are negative or below the limit of detection at the bottom. On the right, you can see the relapse-free survival after transplant in this 100 patients, according to whether the FLT3 level was negative, which is the green curve at the top, or positive in various degrees, shown by the orange, blue, and red lines. And so the main message here is if you're FLT3 positive pre-transplant, the risk of relapse is high, whereas if you're FLT3 negative pre-transplant, the risk of relapse is low. And one hypothesis would be that if you're negative for FLT3, that perhaps post-transplant FLT3 maintenance is not required, thus sparing the patient the risk of graft versus host disease. The next area I'd like to talk about is the indication for patients with secondary and therapy-related AML. We know that CPX-351 has been around for a number of years now because of the pivotal study showing benefit in this group compared to conventional 7+3. A new piece of information which came out at ASH last year was trying to address the question whether the new classification and designation of patients with myelodysplasia-related mutations, or MR-AML, might also be an indication for CPX351. This was based upon data presented by Jad Ottman at ASH, showing that this sub-analysis of a UK trial comparing flag-idarubicin versus CPX351 in patients who had adverse cytogenetic risk. And what they did was they looked at this group of patients with MDS-related mutations, which you can see in the third box there, which is how patients with these mutations led by ASXL1 are classified by the new ICC classification, which was published in 2022. So in patients that had one of these mutations, ASXL1, BCOR, etc., Jad showed that there was a benefit for CPX351 shown in the red curve compared to flag-idarubicin amongst patients that had adverse cytogenetic risk. You can see still a small study, needs to be confirmed further, but certainly an intriguing possibility for the further use of CPX351 defined by mutations rather than by clinical features. The next area is a discussion about what to do with patients that are fit for intensive chemotherapy but don't have a FLT3 mutation, don't have secondary AML, and don't have non-adverse cytogenetic risk.
Before you go on, I just want to clarify that last paper that you talked about. So these were patients who did not have secondary AML, they just had high-risk AML.
Some of these patients would have had secondary AML, but not all of them. And many of them were defined purely by the presence of mutations rather than a prior history of MDS or a prior history of therapy-related AML.
So were these mutations the kind that are normally seen with MDS, or there's just high risk in general?
No, these are now a group of mutations which are highly related to patients with a history of MDS. And so the thought is that using mutations to define MDS-related AML is perhaps more accurate than just a clinical history.
Okay, that makes sense. Thank you.
So this study, which was performed as a sub-analysis of the pivotal trial by Jorge Cortes and published last year, looked at patients with adverse risk AML and asked the question whether CPX351 displayed any potential benefit over 7+3. And as you can see here, there was a small benefit with respect to CPX351. And this is important because the key question for clinicians at the moment is in patients with adverse risk AML, age over 60, should you use CPX351 or is Ven/Aza a possibility? Looking at this curve on the right, you can see that perhaps the benefit is not large. However, when you look at the post-transplant outcomes, you can see that CPX351 does produce a 3-year survival, which looks quite substantially improved over 7+3, along with the slight increase in response rate on the left, 41% versus 29%. And so it really does ask the question whether we should be using CPX351 followed by allograft, or whether we should go with Ven/Aza followed by allograft, and really future randomized studies will be needed to fully define the answer to this question. The next area I'd like to address is the area of unfit AML, and currently there are 2 indications with overlap between patients who have an IDH1 mutation with respect to ivosidenib plus Aza, or whether Ven/Aza should be the standard of care. Obviously, for ivosidenib, one needs to do rapid testing to identify the IDH1 mutation, whereas for Ven/Aza, this doesn't require pre-treatment risk stratification with genetic testing. And so really, we don't have a randomized study between these 2 treatment options, but 2 separate studies which show on the left the benefit of ivosidenib over placebo with respect to its combination with Aza, and on the right the results with Ven/Aza, both in the IDH1 mutant subgroup. So in the table, You can see the number of patients treated. The median age was identical between the two studies. The response rates were slightly in favor of Ven/Aza, but not a randomized comparison. The true CR rate slightly higher for ivosidenib, and the median survival down at the bottom, fairly similar between the two treatment options. And so really it comes down to, one, can you do rapid IDH1 testing to allow ivosidenib to be selected? Two, I think most clinicians feel that perhaps the myelosuppression is less with ivosidenib. And three, it still opens the possibility of using Ven/Aza after Ivo/Aza if patients fail. So I think in general, most clinicians are in favor of using the targeted approach. The next area to address is to update you on some of the long-term outcome data which was recently presented with respect to Ven/Aza, which is now currently used for many patients who are considered unfit for intensive chemotherapy. So on the left, there is outcome data now with over 40 months of median follow-up presented by Keith Pratt at ASH last year. And on the right is a publication which came out in Blood, also updating the long-term outcomes of low-dose Ara-C plus Ven in the elderly unfit population. And I think the main message from both of these studies is that although there has been a substantial improvement with the addition of venetoclax in older people, you can still see that the survival curve does decline, and long-term survival is only going to be apparent in about 15 to 20% of patients long-term. So cure is still a very difficult concept to achieve in older people. Yes, there has been substantial improvement, but clearly understanding the mechanisms of resistance and relapse and further improving this backbone with additional drugs or additional strategies will be required. Another message which has come out from the long-term follow-up studies is the question as to which molecular subgroups benefit most from these two approaches. And on the left, you can see that the group which benefits the most from Ven/Aza are patients with IDH mutation. You can see a very big survival benefit compared to no addition of venetoclax. And on the right, with low-dose Ara-C plus venetoclax, it has now been shown in multiple studies that NPM1 mutation, the green survival curve on the top, appears to be the subgroup that benefits the most from this particular regimen. CPX-351 has also been combined with venetoclax for patients who are considered unfit for intensive chemotherapy. Early results, but very promising response data shown on the right. And more information clearly needs to be achieved in the future in terms of comparison with other conventional agents. The other area I'd like to address is, are there any attempts to further improve the role of 7 and 3 in patients fit for intensive chemotherapy? And one strategy which is being looked at is whether the addition of venetoclax could provide a therapeutic opportunity for the future. And so listed here is a table of the various trials which have been done showing the feasibility and the efficacy of adding venetoclax to an intensive chemotherapy backbone. At the top is the only study showing intensive chemotherapy in combination with venetoclax, the CAVEAT trial. And in the red squared box, you can see the various trials combining intensive therapy, either 7+3, clear, or flag idarubicin in combination with venetoclax. You can see very high response rates with these various options, and I'll talk about two of the key treatment options in the next two slides. So the first is the older population. This was a trial that we published first in JCO in 2020 and updated at ASH last year. You can see the CAVEAT trial, median age 72 years and median follow-up over 3 years now. This is a very well-tolerated regimen in older people, and there are two particular subgroups, NPM1 mutation and IDH2 mutant patients, where you can see the response rates are almost 80%. In this subpopulation of patients, and the 3-year survival over 50%. And so I think this becomes a very important and useful option to consider, because patients only require 1 cycle of therapy, and after that, treatment is minimal and producing very good outcomes. In the younger population, flag, idarubicin, and venetoclax is a regimen which many clinicians are considering, especially in patients that have adverse risk. And you can see the two major studies published, one by Donato and the other by Shazwa, showing slightly different approaches. And on the right, under modified, I've listed our approach, which is sort of a combination of the two, which I think is most clinically relevant. So with fludarabine, we do use the same dose as Donato, but we do incorporate a dose reduction for people over the age of 60 as recommended by Shazwa. With respect to Ara-C, we also do the same thing by recommending a dose reduction for people over the age of 60. With respect to GCSF, we use pegylated GCSF at the completion of therapy, which we think makes most sense. With respect to the idarubicin, we've elected to use the lower doses of idarubicin as illustrated by Donato rather than by Shazwa, because we feel there is a level of toxicity of combining idarubicin with venetoclax that would favor a lower dose. And lastly, the venetoclax, we've used the regimen by Shazwa, which allows incorporation of posaconazole because most of these people will develop severe neutropenia, and we've elected for a day one run-in with venetoclax without combination with chemo just to mitigate the risks of TLS. We hope that this modified regimen will guide clinicians out there as to how best to use flag idarubicin with venetoclax. The next area to discuss is a new indication or a new drug for patients with relapsed and refractory AML, which is targeting a new subgroup not currently targeted by existing drugs. And this is in relation to the exciting development of menin inhibitors, of which there are a number in clinical trials, of which the Augment 101 using SNDX-5613 is one of them. You can see here the two populations targeted by this menin inhibitor are patients with KMT2A rearrangements and also patients with an NPM1 abnormality. The main potential adverse risk is differentiation syndrome, which is manageable if appropriate measures are instituted. And you can see here very, very promising response rates in relapsed and refractory patients with multiple prior therapy failures, 60% almost with KMT2A rearrangements and almost 40% with mutant NPM1. Both of these studies now have been published recently in Nature, and on the bottom was some very interesting and intriguing data presented from Scott Armstrong's lab, where you can see exposure of patients to menin inhibitors has now resulted in the emergence of some menin mutations, on-target mutations, which block the activity of menin, which interestingly seem to occur quite quickly. And so this will be an incredibly important area for the field to try and understand further. I mentioned SNDX-5613. However, there are other menin inhibitors coming through with ziftomenib, another major option, which you can see on the top left there. And interestingly, this agent appears to have slightly more activity in patients with NPM1 mutation, but small numbers, and I think we need more follow-up data to really distinguish between the two menin agents in frontline clinical development. And lastly, this is a slide on the development of Syk inhibitors, entospletinib. And this was an agent which was being examined in a pivotal frontline trial in combination with intensive chemotherapy with NPM1 MRD clearance as the primary endpoint. And unfortunately, it was announced that in November last year, this study was terminated by the company because of difficulties of enrollment. And the company is now focusing on the development of a next generation Syk inhibitor called lanraplenib in combination with FLT3 inhibitors. And so it remains to be seen whether Syk inhibitors will eventually have a role in AML. The next area is patients with FLT3 mutation who have relapsed after prior therapy. Currently, we have gilteritinib available for this setting. And there was long-term data presented by Sasha Pearl in this publication showing that really there has actually been a long-term separation of the two curves between gilteritinib and conventional care in red at the bottom. And so the main message from this is that gilteritinib, even in the salvage setting, can actually produce long-term remissions in some patients. You can see all the censored events there on the blue curve stretching out beyond 3 to 4 years. And really, this drug has had a very important impact in this patient subgroup. So the next question is, how can we improve upon gilteritinib? And there have been many attempts to try and combine gilteritinib with conventional agents such as venetoclax and also venetoclax plus azacitidine. I'm going to discuss with you the results presented by Nick Short from MD Anderson at ASH last year, showing the triplet combination of aza-ven gilteritinib in the frontline setting with the survival curves on the bottom left and in the relapsed refractory setting on the right. The key message is that this is a myelosuppressive regimen because of the very long half-life of gilteritinib, and this results in the need to reduce the doses post-induction, which you can see on the right, with azacitidine truncated to 5 days compared to 7 days, venetoclax halved to 7 days instead of 14 or more days, and gilteritinib, the dose reduced from 120 to 80 milligrams. And it's important to consider these dose adjustments, otherwise severe and prolonged myelosuppression can result. However, with these dose adjustments, you can see in the green curve on the left, the survival in frontline use for patients with FLT3-ITD. You can see the neutrophil recovery is 37 days, platelet recovery 25 days, as I mentioned before, myelosuppression being the major issue. And so it's hoped that this combination will be taken forth into validation studies in the future. The next study is in relation to IDH1 mutant AML. And there's a new drug which has come out called olutasidenib, which has been approved and now provides another option in conjunction with ivosidenib for patients with IDH1 mutant AML. So olutasidenib, or FT2102, is a new option for IDH1 mutant AML with relapsed refractory disease. You can see response rate almost 50%, and the blue curve showing the survival of patients with a response, which looks quite promising. Well-tolerated drug, as you would expect from a targeted agent, and now definitely a competitive alternative to ivosidenib in this setting.
I'm just kind of curious. I don't know if there's a nickname for the new IDH inhibitor, but any way to compare indirectly either efficacy or tolerability to ivosidenib?
I think because the population was different, it's going to be difficult to say that one is superior to the other. Both agents are well tolerated. Both have potential risks of differentiation syndrome. Both can cause some reversible liver complications. Both have shown good response rates and molecular clearance. So I think it's going to be a difficult choice at this stage until we have more information on the tox profile from the two agents in terms of full publication, and also whether these agents will be able to be combined effectively with other agents with respect to drug-drug interactions and PK issues. So I think at this stage, they're both available, but too early for us to pick one over the other.
All right, please continue.
The next area I wanted to focus on was the situation of IDH2 mutant AML in the relapsed refractory setting. Enasidenib is available in the United States, but unfortunately not available outside of the US. And there have been some further studies. This was a study presented by Stéphane Dupeton, presented at ASCO last year. And this was an interesting study because he looked as a post hoc subgroup analysis of the pivotal trial of enasidenib versus conventional care in patients with relapsed and refractory AML, and looked at whether there were any differences between patients that had the R140 isoform of IDH2 versus the R170. On the right, you can see that overall, enasidenib compared to conventional care had a better response rate, but there was no improvement in survival. However, if you look at the two subgroups, R140, which was present in almost 3/4 of patients, you can see that there was a slightly different co-mutation profile with more FLT3 and NRAS mutations, whereas the R172 patients had more P53 abnormalities as covariants. And you can see that the response rate, interestingly, was higher for enasidenib in the R172 subpopulation, as well as the median overall survival, suggesting that perhaps these isoforms don't behave the same, and that IDH2 inhibition may have a more selective and more beneficial role for patients with the R172 isoform. And there have been attempts to combine enasidenib with venetoclax, and also the triple combination of enasidenib, venetoclax, and azacitidine in IDH2 mutant AML. This is the doublet first, enasidenib plus venetoclax, data presented previously by Steve Chan, showing that in 11 patients, 10 of whom had relapsed refractory disease, that there were 5 responders. So early days on the right showing that molecular reductions can be achieved with this doublet. And on the next slide, you can see here, this is new data presented with respect to the triplet, azacitidine, enasidenib plus venetoclax. On the left, you can see the results amongst patients who received this triple combination in first salvage or second or subsequent salvage, and on the right are the results of the triplet versus the doublet in first-line therapy. So really, you can see the triplet combination does appear to have its best efficacy in first salvage or frontline therapy. Whether this is going to be better than Ven/Aza or other possibilities remains to be seen, but definitely an interesting alternative for using venetoclax in combination with other standard agents. Lastly, I just wanted to finish up by highlighting the use of decitabine in combination with cedazuridine, an oral combination in one tablet versus IV decitabine. This was the results of the Ascertain trial, which was a pharmacokinetic study, which started off with oral decitabine versus IV decitabine, and then there was a crossover in the second cycle, and then all patients continued on with oral decitabine thereafter. And really, the main result and message from this trial was that these two agents are bioequivalent. And so people have resorted to using oral decitabine where IV decitabine was currently used. Now, although they are pharmacokinetically equivalent, many clinicians have found that the 5-day schedule of oral decitabine cedazuridine is quite myelosuppressive, resulting in some clinicians reducing, particularly in combination with venetoclax, the dose of this oral agent to 3 times a week, Monday, Wednesday, Friday, compared to 5 days a week. Now, this is a clinical practice option, not shown in clinical trials yet whether this is sufficient and beneficial, but certainly there's the observation that perhaps this agent is a bit more myelosuppressive, even though pharmacokinetically similar concentrations were achieved. So that was the year in review in AML. I hope some of this information was of use to you, and I look forward to speaking to you again in the future. Thank you.
So that was great. Just a couple of follow-up questions. When you look back over this past year and think about some of the newer developments in AML, from your point of view, what are some of the ones that maybe 2 or 3 developments that you think are most relevant to the general medical oncologists and community-based practice as opposed to AML investigators?
I think the use of MRD is definitely becoming a more important aspect. So measuring small amounts of disease, which allows us to make more rational decisions before patients become clinically unwell. I think the notion of targeted therapy with menin inhibitors in conjunction with previously approved drugs targeting FLT3 and IDH are important, but also recognition that drug resistance and mutations resulting in clonal evolution will almost be inevitable, particularly for a rapidly evolving disease like AML, and that utilizing MRD strategies to identify these clonal changes and perhaps in the future adapting our therapy rather than waiting for clinical relapse, I think for me has emerged as a future theme.
In terms of clinical trials, clinical research, what are some of the trials that are sort of in ongoing that perhaps we're going to see some data on the next 6 months or a year that you think might have an important impact both on practice and future research?
Yes, the Morpho results we hope will be presented at a congress in the near future is one which is critically important, and one which was a bit baffling to many clinicians, where we really thought this was going to be a home run. The results of two major frontline venetoclax or frontline trials in high-risk MDS, I think, are incredibly important. The Verona study, which is Ven/Aza in the frontline MDS setting, and also the sabatolimab plus Aza trials. I think the results of these are really important because we don't have any new drugs in MDS. And furthermore, the Ven/Aza option is important because with the new revisions of the AML classification, there are more people using Ven/Aza for people with blast counts below 20%. So I think having data to inform this practice is going to be really important. There's also a trial called Amadeus, which is oral azacitidine randomized to placebo after allograft as a maintenance option. And I think the result of this will also be important because we already have oral azacitidine as a maintenance option for patients with AML in remission. So whether we can use it post-transplant also, I think will be critically important. And also we hope that the results of the Quantum First study with quizartinib, we're really waiting for the FDA approval of this, which is actually expected any time now. And so once this is available, this will become a new FLT3 inhibitor that will ultimately change practice. So those are the key studies which I think are on the near horizon.
Anything new in terms of magrolimab?
Yes, I forgot to mention that one, but magrolimab is being examined in a number of pivotal frontline studies. So the major one is in MDS, high-risk MDS, which has been completed, which is Aza magro versus Aza placebo, and we hope that that will be positive. There's also trials looking at its role in sort of P53 mutant AML, and also in triple combination with venetoclax, Aza magrolimab in the frontline setting, and that's called Enhance-3. That study is still early in development. With the magro Aza option, two papers have been published recently, both in JCO. First is already out. The one is about to come out in MDS and AML respectively. And this agent does appear to substantially improve the response rates. And the key question is whether survival will be improved with this option. And we'll have to wait for the result of the Enhance-1 trial to find that out for MDS.